is Dr. Suryo Adi Utomo. It's a special presentation because it's a fellow with the BRICS program. Everybody remember BRICS. Please, Dr. Suryo Adi, this is very interesting case.
Thank you, Dr. Sunaria, for the introduction. Good afternoon, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. My name is Suryo Adi Utomo from Surabaya. First of all, I would like to say thank you for APAC committee and also the Chin Foundation for having me here. Today, I would like to present my case when I'm fellowship training in China. It's that case titled Microaxialflow pump on top of Atrial Septostomy for AV decompression strategy in APAC-supported myocardial function cardiac shock. As an introduction, as we know that myocardial function cardiac shock comprises 5 to 10% of acute MI complication, and it causes high mortality and morbidity. We all know that early perfusion is a therapeutic that increases the survival of acute MI cardiac shock. But sometimes we found a severe or worsening clinical presentation despite hemodynamic support and also successful perfusion. It is called refractory cardiac shock. And for this subset of patients, use of advanced mechanical circulatory support are recommended. But however, sometimes advanced mechanical circulatory support cannot always help, but instead causes new problems. We start with the case, male 78 years old. He has an acute inferior MI 3 weeks ago and hospitalized in a rural hospital with no received reperfusion treatment. And now with persistent chest pain and referred to our hospital. And the CT shows ST elevation in the inferior wall with pathological QVF and complete RBBB. The echo shows decreased ejection fraction and functional atrial regurgitation. The patient also had comorbidities like heart failure, renal dysfunction, and also anemia. At the first, we plan to do the conservative treatment for this patient. However, at the first day of hospitalization, a patient has developed ventricular tachycardia with an increased high sensitive troponin more than 10,000 and the blood pressure dropped with the 80 over 50. Based on the STEMI guideline recommendation, we should do the primary PCI strategy for this kind of patient. And we do the primary PCI with the IVL support, and the coronary angiogram shows the totally occluded right coronary artery in the mid part, and there's large thrombus burden at there. And then we do the thrombus aspiration, laser evaporation, and thrombus was successfully aspirated. After we do standing with the IVS optimization, we do the successful reperfusion for this patient. The patient is going stable. However, 2 days after primary PCI, the patient suffered from frequent PVCs and developed recurrent ventricular tachycardia with the blood pressure drop at 70 over 33 and the patient undergoing cardiac shock and respiratory distress. Lactate levels increased 0.7 to 1.8. Even after intubation, mechanical ventilation, inotropic vasopressor drugs with the vasopressor electron score was 30 with the norepinephrine, and patient is already on IBP. The hemodynamic remains unstable, and then we institute the VA ECMO for this kind of refractory cardiac shock, and we achieved temporary stabilization at that time. However, after VA ECMO implantation, the ventricular tachycardia is more frequent and difficult to control, even after antiarrhythmic drugs, cardioversion, or deep sedation. And the hemodynamic instability is persistent. There is shock, cardiac shock, and we see the chest X-ray, the early sign of pulmonary edema exists. At that time, we think about the cause of this deterioration, and we do the evaluation of CAG. CAG evaluation was good, the stent thrombosis, and the electrolyte level is normal. So we think another cause, is it caused by VA complication? As we know, the hemodynamic effect of VA is ECMO withdraw the blood from right atrial femoral vein to the ECMO and put send the blood, oxygenated blood to the femoral artery, which causes increased LV afterload. If the heart is unable to compensate this increased afterload, we can develop the increased LV-DP, LV distension, and increased LR pressure. And this patient has developed this LV distension syndrome. The ejection fraction is decreased to 21%, and the LV internal diameter is increased to 71 millimeters. So along with refractory arrhythmia and pulmonary edema is called LV distension syndrome. So multidisciplinary team discussion suggests we do have to do the decompression strategy to this patient. At the first, we do the right hand catheterization to know the intracardiac pressure, and we found that not significantly increase in the right heart pressure. And then we do the transeptal puncture to access the left atrial directly, and found there is very high LR pressure, LF pressure 42/10. Based on this finding, we do the venting strategy using balloon atrial septostomy. We deliver the over-the-wire balloon to the atrial septal position, and we do the balloon atrial septostomy to make a connection with the left atrial, right atrial. However, the LR pressure after balloon atrial septostomy is still high, and the aortic pressure is low. Based on the finding, we do the LV unloading strategy using the Microaxialflow pump implantation. We deliver this Microaxialflow pump to the aortic and LV position, and we try to expel the blood from the LV to be able to decrease the workload of the LV and to decrease the LV-DP. So this is the result. The LR pressure is down to 29/8, and blood pressure increased 123/91. However, the refractory arrhythmia still exists, and we do the overdrive pacing to the patient, and we hear the overdrive pacing, the arrhythmia is disease terminated and going to the sinus rhythm. This is the outcome of this decompression strategy. We had a stable sinus rhythm, no more fitness episode, pulmonary condition is relieved, and improved LV dimension and also LV function. The lambda levels going down to 0.2, VA can win. Microaxialflow pump also win after 3 days. The patient can be extubated, and the patient can discharge after 2 weeks patient care. Talking about LV decompression, after ECMO, we have now the venting strategy or unloading strategy. The venting strategy has a goal to decrease LV, EDP, and pulmonary congestion. Usually we use this method in the heart failure cardiogenic shock. And this method is passive, example is balloon atrial septostomy. The second one is unloading strategy. The goal is to decrease myocardial work, usually recommended in the acute MI cardiogenic shock. And method can be Microaxialflow pump or as an active pump or IVP as a patient pump. However, this is the first reported case that used this stepwise combination of both strategy. And this LV decompression strategy, Microaxialflow pump on top of balloon atrial septostomy as an advantage and also disadvantage. The advantage is it provides immediate decompression, enable direct monitoring of LV pressure during decompression strategy, and atrial septostomy can lower LR pressure and improve oxygenation, reducing the risk of ECMO-related complications like Harlequin syndrome or differential hypoxemia. However, the disadvantage is increased risk. It increases bleeding, tamponade, or limb ischemia, and also increase logistical costs. However, routinely using this combination strategy may not be recommended. However, it can be reserved for the treatment of very severe clinical condition. As a conclusion for this case, in refractory myocardial infarction cardiogenic shock, LV distension syndrome can be developed after VA implantation. And microaxialflow pump on top of balloon atrial septostomy is an effective and safe decompression strategy to alleviate LV extended syndrome, which can be applied in a catastrophic medical condition. Thank you for your time.
Very brave and heroic team in China. I think I would like to give Dr. Rifki a chance. Yeah, and Dr. Paul, because we still have 5 minutes. Wow.
It's a very good case. I wonder if the patient got in cardiac shock after the angioplasty, 2 days after the angioplasty. But we know from the shock trial, the balloon pump doesn't work. We know from the ECMO shock trials, ECMO doesn't work. And for the danger trial, impeller worked. So I'm just curious, why the first device you used seems to be IVP, and then ECMO, and then impeller. But shouldn't the order be impeller, then ECMO? Eventually that's what you did, right? You use impeller. So I'm just curious your thoughts.
Thank you for the question. Actually, in our institution, the microaxialflow pump is not routinely used. In terms of the cardiac shock, we routinely use IVP or VA. The first time the blood pressure is 80 or 50, but the cardiac shock not clinically to full blood. It is only blood pressure is 80 or 50. So the IVP is enough at that time. But after that, the deterioration is occurred, and we escalate to the VA, which one VA is one of the routinely used in our institution. And the microaxialflow is considered as reserve strategy at my institution. Not routinely used because it's not covered by the insurance. It should be yes.
But please.
Very challenging case. I think this patient came after 3 weeks mechanical infarction, right?
Yes.
And then with the hospital PT, and then successfully went to PCI. And then how can you, after this patient come with the recurrent VT and cardiogenic shock? Because I think the patient came to the hospital, the ejection fraction was 45%. Usually the cardiogenic shock occurred in a patient with acute interior cardiomyopathy. This is an inferior. What is the cause of the shock in these patients?
Oh yeah, there's one fact that we have to explain. The patient has a history of anterior MI 8 years ago and had a primary site implantation and already reduced the ejection fraction after 8 years. So it explains the decrease of ejection fraction, not only about the very MI but also the previous anterior. And also the patient has a functional microaxial representation which cause another cause of heart failure.
Because when the patient before PCI, the ejection fraction was 45.
Yes.
So how can we explain the deterioration of the ejection fraction after PCI?
The deterioration of 45 to 21. The deterioration is caused by VA implantation.
Before.
Yeah, and the first time we show patient in our hospital, the baseline is 45. It is because of the patient has a story of acute anterior MI 8 years ago. And the deterioration is caused by refractory disease that cause development of
Okay, so
It's we have to consider the time. Yes.
Yeah, I think all of
probably ask regarding the rationale of your stepwise thing because of your center is reserve the microaxial pump for because I think you would have anticipated this alpha ventricular dilatation because the patient has a secondary MR, is getting LMFP, and then you input the VA ECMO, which we know it would mean this patient is then unloaded.
Yes.
Okay. Thank you, Dr. Suryadi. And the last 2 minutes is for Dr. Richard. Oh.
Presentations are very good and very high standard today. Thank all the audience here for supporting, for staying behind. Thank all our juries, our judges, Dr. Sundaria, Coach Jefferson, for this wonderful session. We will announce the prizes tomorrow at the closing ceremony, and I'd like to thank you all for a very good afternoon. Thank you.
Thank you. Thank you. We will have another session.
Okay, such an amazing session, and thank you for the